Kelly, and I'm the Programme Manager for EviQ. And my background is I'm an oncology pharmacist. So the topic for this evening is cardio-oncology. So cancer treatment-related cardiotoxicity, it was initially observed way back, as early as the 1970s, and it's well established with the use of anthracyclines, trastuzumab, and radiation therapy to the chest. However, there's been an array of new agents that have been emerged from the innumerable number of tyrosine kinase inhibitors, immunotherapy, that's including the checkpoint inhibitors, and all of these have introduced unexpected cardiovascular complications. So therefore today, for our cancer clinicians, the balance between the benefits and risks of a cancer treatment in the context of cardiovascular status of the patient, it can be really challenging. And also, we've got a large group of cancer survivors who now have exposure to these cancer therapies, so we need to determine optimal long-term cardiovascular surveillance and management. So a subspecialty with a multidisciplinary integrative approach between cancer clinicians and cardiologists has emerged to address these issues, simply termed what the topic of this evening is, cardio-oncology. So this increase in awareness of the subspecialty has resulted in numerous meetings, numerous subspecialty meetings, pop-up of cardio-oncology units. As we'll talk about the experiences of COSA, had a content stream on cardio-oncology. There's even a journal by the American College of Cardiology dedicated to cardio-oncology. And I even noticed in Professor Marwick's bio that he is an associate editor of this journal. So moving on to the presentations. So as I mentioned, COSA, cardio-oncology is one of the themes. So we've got a multidisciplinary panel here this evening. And I'll introduce each of them now, and to hear about cardio-oncology from their specialty perspective. So our first speaker is Professor Tom Marwick, and he's the director of the Baker Heart and Diabetes Institute, and he's divided his career mostly between Australia and the US. He's one of the initiators of stress echocardiography and has made contributions to the prognostic evidence underlying cardiovascular imaging. And his main current research interests relate to the detection of earlier cardiovascular disease and cost-effective application of cardiac imaging techniques for treatment selection and monitoring. So I'll now hand over to Professor Marwick for his presentation.
Thanks, Aisling, and thanks everybody for joining and for the very kind invitation. I'm hoping that you will be able to see my slides. How's that going? Are you able to see them okay?
Yep, all good.
Okay, thanks again for the invitation. Let me perhaps start off with a patient who I think encapsulates the problem, for me at least. So this is a lady that I saw a couple of years ago, age 62, who 12 months before her presentation to the cardiology clinic had had treatment for breast cancer, HER2 positive, treated with trastuzumab, epirubicin and some other agents, and was deemed cured. However, she developed shortness of breath, which is the reason why she came to the clinic. And we found her to have an impairment of cardiac function. So I'm trying to make these loops run, but they're not. I guess one of the joys of Zoom. But you can see her here, the picture of her heart before the chemotherapy and then when she came to see us. And the things to point out is that the cavity of the heart, this is the main pump of the heart called the left ventricle, has enlarged, as has the left atrium, the priming pump of the part of the heart. And if I could show you the loops, you could see that this is contracting less. In fact, this ejection fraction before the chemotherapy was in the normal range, in the sort of 55 to 60% range. So essentially, she has heart failure. And as cardiologists, we worry a lot about heart failure that originates from chemotherapy. These are different sorts of heart failure, survival curves. You can see here follow-up over years and then the proportions of patients surviving from their heart failure. And heart failure due to chemotherapy is something that we really, really want to avoid. So in the next few minutes, I'm going to talk about a few of these issues that pertain to the assessment of this problem. And I think the first place to start is its definition. So like all standards, the nice thing about standards is that there's so many of them. There are at least half a dozen, probably more, criteria for diagnosing cardiotoxicity, but they have some commonalities. First of them, all of them are about this measurement called ejection fraction, the amount of blood that the heart pumps with each beat. And there are two aspects to this. One, that this ejection fraction has to fall by 10%, and secondly, that it has to fall below the normal range. So pretty well all of them talk about ejection fraction. Just one of them talks about some new markers, myocardial strain and biomarkers, but ejection fraction is kind of the common currency. Now, as I'll show you in a minute, there are some problems with ejection fraction, and fundamentally, if we dial back from where we are now to thinking about what we need to have a solution that will work in large numbers of people because, as Aisling mentioned to you in the beginning, there are happily increasing survivors from cancer, but some of them are at risk of cardiotoxicity. It needs to be an accurate test. It needs to be a consistent test. Not all patients have the same risk, and therefore we need to understand risk on clinical grounds. And here comes our first problem that you heard already that anthracyclines were known in the 1970s to produce problems with cardiotoxicity. Here is the dose of the anthracycline. This is a further study in the 2000s. And the sort of cut point that has been used or was used initially is 400 milligrams per meter squared. But if you look at beneath this cut point, you can see pretty significant numbers of patients developing heart failure. And the message here is that it's not just about dose. So people exposed to lower doses of anthracyclines can get into trouble. And it's not just a story about chemotherapy. So here you can see the drivers of heart failure and cardiac dysfunction after chemotherapy. Anthracycline use is important, as is radiation, but there are a number of other things that are important, such as other heart disease, high blood pressure, coronary disease, diabetes, age over 65. Some of these things are intervenable on their own, and that's an important perspective to keep. So I've already mentioned the use of ejection fraction, and I think many patients and members of the public are familiar with this term. It is something that has been used in cardiology for probably 5 decades, and it is a very useful marker of outcome. So here you see individuals with an ejection fraction of less than 40% and their mortality, and the two are very closely linked. However, when we're dealing with people who are close to the normal range, and the normal range of ejection fraction is about 53%, you can see that there is quite a variation of outcome here. So this is not a good predictor for the people that we want to study who have initially a healthy heart who are exposed to chemotherapy. Second problem is that there are a host of technical problems with ejection fraction. I won't go into them in detail. I'm happy to come back to them, but it means that the tool is not useful for everybody. Third, ejection fraction is dependent on load. So when I see a person on 2 occasions and their blood pressure is 140 on one occasion and 175 on the next occasion, that on its own can impact on ejection fraction. And it doesn't necessarily mean that the ejection fraction has changed because the heart is sick from the chemotherapy. So sensitivity to change and reproducibility of the test are important as well. I have an example here just to show you how impactful this is. So this is a patient in my echo lab who happened to be studied twice on the same day without any change of their status. And you see up top here 2-dimensional images of the heart. So this is the heart cut through as a 2-dimensional object. Obviously it's a 3D object, and underneath that you see a 3-dimensional ejection fraction. So the message here is that when I got 2 sonographers to do this image twice in a day in a stable patient, they got very different measures of ejection fraction. Now, both of them are normal ejection fractions, but the point is that the measurements are different, much more consistent with this 3-dimensional technique. This variability is really important in the assessment of cardiotoxicity. So very important paper showing the coefficient of variation of ejection fraction is 15%, and the 95% confidence interval is 11%. So when I see somebody in the clinic and their EF one day is 60%, and I see them the next time and it's 52%, that is not a meaningful change of ejection fraction, and it's very important to keep that in mind. So with those problems, we set out a number of years ago to start measuring a new parameter called myocardial strain. And this is a fundamental property of anything, really. It's a physical property. It relates to how a substance deforms in response to an applied force. And the force that we use, obviously, is the heartbeat. So we use a technique for measuring the length of a piece of muscle in the beginning of contraction and at the end of contraction. And this difference, indexed to the original length, is called the myocardial strain. This is how it works. So this is a patient that we have, again, unfortunately, my loops won't work, which is a shame. But this is a patient where we studied on 3 occasions under treatment with trastuzumab. So baseline, 6 months, and 12 months. Patient starts off with an ejection fraction of 61%, normal, and a strain, global longitudinal strain, GLS, of 20%, also normal. At 6 months, the EF has fallen 55%, but I've already told you this is not a meaningful change. It's not below the normal range, and it's not a 10% change. However, this change of 3%, absolute change of 3% of GLS, or a relative change of 15%, is, we now know, a meaningful change. We didn't know that in 2011 when we took these pictures. And we continued the patient on treatment, and the ejection fraction fell further and the GLS fell further. So what the strain is doing is kind of giving us a window to what the ejection fraction is going to do subsequently. It's a more sensitive tool. And this is a meta-analysis. It's a combination of multiple studies that was reported a year ago that emphasizes the value of this relative change of strain. And the cut point we use is a 12% change, but there have been cutoffs between 10 and 15% relative change of strain. So this is what we now do. So this is the first patient that I showed you. This is what we would do in the current era. We'd check the patient at baseline, both normal. We'd check them in follow-up. The strain has fallen. In fact, by 24%, the ejection fraction is still in the normal range. We would say here, ignore the ejection fraction, start some cardioprotection for the patient with beta blockers and ACE inhibitors, and the strain then improves. And I'm very proud to be able to tell you the results of the SECURE study. This is a made in Australia study, a multinational, multi-center trial, which we have just reported in the Journal of the American College of Cardiology. It randomized patients to strain-guided therapy or ejection fraction-guided therapy. I won't go through the detail there. And the bottom line is that when strain was used, we identified a reduction of strain in 37 of the 154 randomized to strain guidance. And this allowed us, gave us the warning signal to start cardioprotection. And we believe as a consequence of that, the frequency of cardiotoxicity at 12 months was less than 6%. In contrast, those randomized to ejection fraction guidance, we couldn't pick up this subclinical dysfunction. We were only able to see the ejection fraction change. We treated fewer patients because we didn't know what was going on. And as a consequence, more people ended up with cardiotoxicity at 12 months. So we look upon this as a means of identifying earlier disease where we can intervene earlier and therefore preserve ejection fraction compared to using ejection fraction only. So there are some alternatives. Magnetic resonance imaging, or MRI, is another alternative. It's expensive and its availability is rather less than echocardiography. But the really good thing about it is that it can characterize tissue. So we use this technique for identifying inflammation in the heart, various sorts of thickening of the heart muscle, using various techniques called T1 mapping and extracellular volume measurements and T2 mapping. The point is, with all of these things, is that our hope is that we can identify injury to heart muscle before the function deteriorates. At the moment, we don't know whether this is going to be effective or not, but there are several trials in process. And finally, the other thing that has been used is biomarkers or blood specimens to check for troponin levels. Troponin is a marker of heart muscle injury. It is very, very sensitive. So somebody going for a run can get an elevated troponin. And as a consequence, the troponin is very meaningful if it's persistently negative. You can see these, persistently positive. You see these patients getting into trouble here, or persistently negative. But in the patients where the troponin is positive on one occasion and negative on another, it's a bit more difficult to figure out what's going on. So, Aisling, we have a lot of information about this problem of cardiotoxicity, and like you, we're concerned that this is going to become more of a problem because some of the new drugs that are being developed for cancer have an effect on the heart. There are a number of areas of development, but my guess is that ejection fraction will become less important with time. We'll use myocardial strain, and in some situations we'll use magnetic resonance imaging. We'll identify people earlier before they develop a problem, and we'll initiate treatment to stop them developing heart failure. Thank you for your attention.
Hey, thanks very much for that presentation. I'm just looking at the chat. We have one question. So what about nuclear medicine gated heart pill scans?
Yeah, so nuclear medicine scans have been used historically for this purpose. They're certainly an old technology. There are some problems with them. They only give measurement of ejection fraction. They don't provide other information such as looking at the valves and looking at the filling of the heart. And they're not as sensitive to minor change as strain is. Fundamentally, the problem is the assessment of ejection fraction more than it is the technique with which it's done. So our belief is that looking at deformation of muscle is the most sensitive means of identifying a reduction of function.
Okay, is there any other questions in the chat? I have a question, if we'll wait and see if anyone else types one. You mentioned about the preventative medication. So the preventive medication, I presume it's the commonly ones used for heart failure, ACE inhibitors and beta blockers and things. So is that, would you think that's going to be a place in therapy, or will we be seeing it soon? And when are these agents started, and etc.?
So, yeah, really, really good question. So the first thing is that each of those medications has a small evidence base in this setting. So there have been some small randomized controlled trials, usually 100 people or less. When you consider that cardiotoxicity develops at most in 20%, and I'm not even talking about a reduction of ejection fraction, I talk about a reduction of strain, those numbers are really insufficient. So I'm pleased that you asked that, because we have a follow-up study to the SECURE study, which is called SECURE MRI, where people who develop a reduced strain with a preserved ejection fraction will be randomized to that treatment, yes or no, and we'll find out to what extent that's effective. The other thing is that there are a number of other protective medications that are under development or have been developed, which need to be trialed in this space. So I think there probably will be a more sophisticated strategy for addressing this, but at the moment, beta blockers and ACE inhibitors are where the evidence is.
Okay. We have another question. So have you reviewed the effect of early exercise intervention to reduce myocardial strain?
Yeah, so there's a lot of interest in the use of exercise in this setting. My colleagues here at the Baker, Andre Lagersh and Erin Howden and their group have been working in this space. There are some very favorable positive signals here. One of the things that happens with chemotherapy is a reduction of functional capacity, and it appears that with training you can avoid that. Now the issue is, does the training produce protection to the blood vessels and the skeletal muscle in the rest of the body, or does it produce a direct protection on the heart? And at the moment, I don't think we know the answer to that, but it is certainly a very active area of investigation, and probably, I think, will be effective.
Okay. We have one last one. I think we've just got time. What's your thoughts on cardioprotectants, for example, the dexrazoxane?
I'm very persuaded by the dexrazoxane data. I think that that is very valuable in the protection against anthracycline-induced cardiotoxicity. I'm surprised that it's taken so long to catch on. I think there have been some reservations that the use of dexrazoxane may impair the anti-cancer effects of anthracyclines. I think that has largely been put to rest. But my perspective on this is that this is no longer a problem just of anthracycline. I think it's a problem of a host of other small molecules that have tyrosine kinase inhibitors and so on that have potentially adverse effects on the heart. So, and dexrazoxane is a specific protection against anthracycline toxicity, but not the toxicity of those other agents.
Okay. Okay, thank you. Well, I'm sure there'll be lots of collaboration with oncologists, because all these new agents have proved that cardiotoxicity is not created equal, and all the different drugs have different effects. It's not just heart failure anymore. But thanks very much, and we'll now move on to our next presenter. Actually, sorry, Tia, were you wanting to launch a quick poll? I think we were trying to do, yeah, here we go, just so we can get some demographics of the audience. Okay. We'll see if the results flash up so we can see who's who. There we go. Okay. So nursing in the lead. Okay. We'll move on to the next presenter. So our next speaker is Associate Professor Ing-Siew Ko, a Senior Staff Specialist in Radiation Oncology at Liverpool Hospital, and a Conjoint Associate Professor at the University of New South Wales. So Associate Professor Ko has over 17 years experience as a researcher and subspecialty interests in neuro-oncology, breast, lung and hematological cancers. And our current major research directions include all aspects of neuro-oncology, and secondly, cancer survivorship research, including novel models of care and the late effects of cancer therapies with a focus on cardio-oncology, and the effects of chemotherapy and radiation on cardiovascular function. So I'll now ask you to share your slide. Thank you.
Good evening, everyone. It's a pleasure to be involved in this forum. So my task in the next 15 minutes is to provide some perspectives as a radiation specialist and how it relates to the field of cardio-oncology. So what I'd like to cover is some of the understanding of the contribution of radiotherapy to radiation-induced cardiovascular dysfunction and changes, touch on some aspects where I think the field is at and where it is moving in the future, and speak about the elements of a research-led cardio-oncology model of care that we are moving to and should move to in the future. So let's first start by way of background, and I know that most of the people tonight are well aware that radiation therapy or radiotherapy has a very significant role in improving outcomes, both survival and local control of cancers, particularly breast cancer, lung cancer and lymphoma, as we're focusing tonight really on cardiac and cardiovascular structures. We do know, however, that following up patients over a long period of time, we're aware clinically and through the literature that there is a range of cardiovascular toxicities and side effects from radiation, But unfortunately, at the moment, we don't have particularly robust or accurate models that help us predict which patients at what time are at risk for which particular problems. And as Professor Marwick has already highlighted in his presentation, we have the additional factors of the patient to consider, what cardiac risk factors they already carry in terms of their health, their weight, their smoking history, etc. The additive effects of systemic therapy, which we'll hear of in a moment. All these need to be combined and need to be considered together. So most people will be aware that modern radiation therapy techniques have evolved very much substantially in the last number of decades, and that radiation directed to a particular anatomical area of the body is very targeted, highly conformal, and we've seen significant reduced side effects from radiation, both people going through treatment, the acute toxicity, but importantly also the late toxicity that can occur months or manifest even years after radiation treatment. There's a particular technique which most centres within the country and around the world in metropolitan centres will have, and that's called volumetric modulated arc therapy, or VMAT for short. But essentially these are very focused conformal treatments, and you can see here in the image on the left, this is an axial CT slice from a planning scan from a radiation patient having left breast cancer radiotherapy after their surgery. And we see also that the heart is contoured there, and we see that despite the conformality of the radiation, we see that the radiation unfortunately still does need to go through or traverse some of the heart, particularly at the bottom of the heart or the apex of the heart, no matter how targeted the radiation is. And on the image on the right, we see an example of a lung cancer patient who has a left-sided lower lung cancer, and we see a 5-beam IMRT plan, and again we note that the radiation beams need to travel through and exit out of the heart structures, and the question is, what impacts will this have as we follow up these patients? Now, the fortunate thing is that we do have some way of measuring the radiation dose to the heart, and we do that by various measures or metrics. Now, this is a complicated table, but I want to just flag one particular measure called mean heart dose, or MHD, essentially the average dose to the heart. So we contour the heart as one organ, and we calculate accurately the dose, the average dose to the heart as one organ. And you'll see here that there are various situations: lung cancer patients, breast cancer patients, esophageal patients, or lymphoma patients having treatment to their particular tumour, and we can very accurately estimate what the mean heart dose is, and also other volume measures, that is, what is the dose to a particular volume of their heart that they're receiving from the radiation. This is a paper where they looked at over 22 studies involving lung cancer patients and tried to work out which is the most important measure of radiation that will then predict future risk of cardiac side effects. And in fact, in this particular study, there were over 20 different parameters which were linked to outcome. And so the question remains is, what is the most important measure or measures? And I think that the jury is still out. We have mean heart dose, but in fact, as I'll talk to in a moment, that is a fairly blunt measure of outcome, and we've still work to do in this space. As I already alluded to before, we really are, in my view, lacking in an accurate risk prediction tools, so that when we have a patient before us in clinic, we should be able to say to them, based on your health and your cardiovascular risk factors, based on your tumour profile and the treatment we're recommending, both radiation and systemic other therapies, we think your risk is X%, and that your treatment will result in this outcome. We don't really have a safe cardiac dose. We have some measures, as I've just highlighted already, but we don't really have a safe threshold. I'm going to speak to some of the issues that we don't know in a more granular sense what dose is being received by certain substructures of the heart. The heart is not just one homogeneous organ. It obviously has several substructures associated with it. And it's very difficult then to quantify what is the impact of all these different factors. This is a very busy slide, but is one of the main referenced guidelines published in 2017 by ASCO. And I flag it because amongst all the words and all the different risk factors, this is an attempt really by the international community to really flag, well, which patients are most at risk. And I just flag one particular line where it says here, any patient receiving high dose radiation, that is radiation more than 30 gray, where the heart is in the treatment field, should be considered for appropriate surveillance. But really, this is a very general guideline, and in fact, most, or if not all, breast cancer patients will be receiving that dose, as do lung cancer patients. So I think the jury is still out as to which particular patients are at high risk of cardiac late effects and who should we be following and with what particular follow-up protocol. This is really just a schema or cartoon to really flag the fact that we have radiation on the right as a particular therapy that can result in cardiac side effects, but of course we know that radiation can affect not only the muscle of the heart, the myocardium, it can also affect the valves of the heart, the pericardium or the outer covering of the heart. It can have specific effects on the coronary arteries. So there are a range of effects, including rhythm disturbances, that radiation can be associated with, in addition to systemic therapy agents that we'll hear about in the next presentation. I'm just going to move quickly through this diagram, but really just flags the fact that we don't actually have a very good understanding of, on a cellular level, how radiation affects the heart and its various substructures. We think that most radiation side effects are manifest or show up longer term, that is months or perhaps even years, by causing scarring or fibrosis to the structures that receive radiation. But in fact, this particular dogma or belief is actually being questioned by more recent evidence. This is actually a radiograph of a lymphoma patient treated many decades ago, showing, and this particular paper was in a large cohort of patients, almost 2,000 patients who were 5-year survivors of Hodgkin lymphoma, and they range in age from age 15 up to 41, so a young cohort of patient population. And as they followed these patients up over many decades, they actually did demonstrate, unfortunately, that quite a significant proportion of these patients had valvular heart disease subsequent to the radiation. Now, in fact, these patients would have also received anthracycline-based chemotherapy, and obviously they were a lot older at follow-up. But the point of this particular study was that the risk factors for radiation are age at exposure, so patients who are younger are at higher risk, particularly the longer time you follow them up. Long follow-up is required. We used much higher doses of radiation back in the 1970s, 60s, 70s, and 80s than fortunately we do nowadays, and that these risks continue to escalate the longer you follow these patients. Fortunately, in contemporary practice, the radiation volume, the area that we treat, is much smaller, not the whole lymph node groups above the diaphragm, but much more focused to the involved node or even to the involved site. The dose is much less, but even given that, these patients are still at risk of radiation sequelae. Now, this is an important paper published by Darby in the New England Journal of Medicine in 2013, so 7 years ago now. But this is a very seminal and important paper because it actually documented in a large cohort of breast cancer patients the relationship between radiation dose and late cardiovascular side effects. And in fact demonstrated that with every increase in grey, documented using the metric mean heart dose, we saw that this related to an increased rate of major coronary events. And these effects were seen many years after radiation exposure. We have to recognise, though, that in this particular paper, they assumed that every patient's anatomy was the same, and we know clearly that patients differ in their body shape and size. They assumed that everyone's heart structure, it was in the same place, and they only used mean heart dose as the only measure. And as I've already spoken about in this presentation, they did not account for any other risk factors that the patient may have had, particularly their smoking history. Coming to Southwest Sydney, which is where I practice, just from some of our own patients from our cardio-oncology service, we know that these patients have quite significant cardiac risk factors already, including hypertension, high cholesterol, diabetes, smoking history, and indeed that these risk factors are not well documented in the oncology file. And it's important, therefore, that when we assess patients in the cancer clinic, that we not only focus on their cancer outcomes, but that we'll also document their risk factors and any change in their cardiovascular health as time goes on. This is a study that we did locally, which speaks to the fact that the heart is not just one particular homogeneous organ. It's actually comprised of many different components. And this is a study done by one of our PhD candidates, Simon Tang, really dividing the heart into 17 different segments and actually being able to correlate the radiation dose specifically to each segment, and particularly the apex of the heart that I flagged earlier that receives the highest radiation dose. And it's important that we actually have more detailed information about the radiation dose to specific regions of the heart. And indeed, when we look at the studies that are published, they actually matched some of the imaging studies, particularly using particular nuclear medicine type studies, and found indeed that we could actually map some of the spatial changes from radiation, i.e. particular segments that were affected, and we can see these actually manifest using particular imaging studies, and that's important information going forward. The other important thing is that these studies show that some of these changes in radiation actually occur quite early after radiation, even within weeks or even a few months after radiation, not just years later. So again, I think the open question that we really need to focus on is which particular patients are at risk, and we should indeed be following these patients early with a specific strategy and not waiting years to start initiation of relevant follow-up protocols. I think most people attending tonight's forum will be aware of this new technique, which is in widespread use and adoption across Australia and internationally, called Deep Inspiration Breath Hold, or DIBH for short. And essentially, for most patients having left-sided breast irradiation, particularly those having their nodes irradiated, because we know that that particular volume of radiation is associated with a higher mean heart dose. DIBH is a technique where patients are trained to particularly breathe in, take a deep breath in and hold for a certain period of time. And by doing this, it actually moves their heart down and out of the field, reducing the radiation dose to the heart. So this is a very valuable technique, and the majority of patients are able to tolerate this well. On the images on the right on this slide, we see, coming back to my point about the fact that the Derby study assumed that every patient's anatomy was the same, and clearly that's not the case. This is a study where we took the planning CT scans of patients having breast radiotherapy and actually manually contoured not just the heart, but all the substructures or the valves or the coronary arteries in a very detailed fashion. And we actually developed an atlas. And not only was that quite labour intensive when we did it manually, but we've actually developed an atlas where, or a computer algorithm where we can now do that in an automated fashion. So that will be going forward quite a powerful tool, because that will allow us to then accurately document and estimate the dose on literally hundreds, if not thousands of patients, both retrospectively going back, but also prospectively going forward to make this a much more efficient and accurate process. Coming to the final few slides, we have then taken that cardiac atlas and that automated way of documenting dose, radiation dose, and published that now in a large cohort in collaboration with some Danish colleagues in over 1,500 breast cancer patients, showing that we can really use that tool to accurately document radiation dose, and we can expand that much further now. So my final two slides on discussion and reflection of where the field is at as it relates to radiation and cardiac toxicity and cardio-oncology. I think that we really need to work on improving our understanding of the pathophysiology or the cellular changes that occur from radiation, but also the contribution of systemic therapy, the contribution of patient existing risk factors for heart disease. We need to understand spatially where these changes are occurring, not just treat the heart as one organ, but actually to understand specifically which segment, which part of the heart or vessels is being affected. We need to understand temporally over time how and when these changes are manifest. And as I've alluded to, we really need to work on more granular information, more specific dose metrics than just mean heart dose, and to really individualise that to the patient sitting before us in clinic, so we can work with them and their care providers to provide them more specific estimation of their risks. And finally, a comment about a holistic research model incorporating these nomograms or computer algorithms or ways that we can actually understand who is at high, intermediate or low risk and plan their care appropriately in survivors. So in conclusion, I hope that we'll move towards this. It's very important that we have individual patient data, and importantly, I think the good news is that once we identify patients, we can actually mitigate and intervene appropriately with effective therapies. So thanks very much for your attention, and happy to take questions.
Thanks for that, Ingsu. So I received 2 questions. Someone sent them through rather than put them on the chat. So the first one is, are mean heart doses still relevant as organs at risk constraints, or should all patients receiving high dose radiation to the chest have detailed contouring and dose constraints?
Yeah, that's a great question. I think currently in clinical practice, for example, those receiving breast radiotherapy or lung, mean heart dose is the main metric. There are some other measures such as V18, which are basically quantifying dose to the heart. I think ideally, and where the field is moving, is that segmental approach that I was speaking about, a much more granular, detailed way of doing that. But at the moment, it's not quite practical because it is quite labour intensive, but my hope and expectation is that the field will move that way. So I think at the moment in 2020, 2021, we mainly have mean heart dose and a few other metrics to hand.
Okay, and then a question related to the deep inspiration breath hold. So you had mentioned that there was a study. So have any of the have left-sided breast trials using techniques such as the IBH shown long-term reduction in cardiotoxicity and cardiac events?
Yeah, it's a great question. I mean, DIBH has been in practice probably in the last 5-10 years in Australia and early internationally. So we're just starting now to see some of that longer term data. There's no doubt that the modelling studies and the planning studies and what we're seeing in clinical practice show us the mean heart dose is substantially reduced with DIBH, but as to how we see that manifest in reduction of cardiac effects in our patients, I think we'll need a few more years to see that data emerge more strongly.
Okay. If anyone else on chat has a question, if you can type it through, or if anyone would like to ask a question, if you just take yourself off mute. All silent, all having their dinner. Okay, well, I'll just ask Tia if she wants to.
Sorry about that. I'd just like to know if I could get all the statistics that they've spoke about tonight sent to me so I could sit down and read it properly.
Yep, no problem. We will arrange for that to happen in the presentation. So it'll be online.
Good, thank you.
Okay. Okay, Tia, do you want to launch the second question for the poll?
I found out because of the Cancer Institute. They sent me an email.
Okay. Okay, so the direct marketing technique employed worked for this one. Okay, thank you.
Aisling, I've had a direct question that's come through to me as well.
Okay.
So this is for you, Sue, again. Should a cardiologist become part of a patient's healthcare team, and are people's GPs notified of these risks, or can that be part of a survivor's treatment standard?
Great question, and we'll probably come back to this at the end of the forum as well. I think primary care is a very pivotal piece in terms of coordination of care, management of cardiovascular health and optimization. Yes, the Cancer Centre will send out documentation to the specialists involved, as well as their primary care or GP. I think we're improving in our documentation estimation of cardiac risks. We probably don't always put the mean heart dose and quite technical information in the letter. But I think a survivorship care plan is really important going forward. And indeed, in some of my lymphoma patients, I actually might put the image, that radiograph image that I showed you, because the picture just says 1,000 words. I think those sorts of communicator GPs about surveillance is really important going forward.
That's great, thank you. And just one more question, if that's okay. A lot of the cardiology scene is driven by the business of lube and pacemakers, and cardiologists do not seem to be informed about cancer treatment-induced toxicity. How could we get over this barrier?
It's another great question. We might touch on that in the Q&A at the end, but it all comes down to education, and education of our specialist colleagues, GPs, patients, consumers, nursing, everyone involved in the care of our cancer patients. And it's a challenging task to get the word out, and also made more challenging because the field is moving so quickly. The advent of treatments and all the different benefits, but also the side effects, is moving very quickly, and you can imagine that across disciplines it's an incredible challenge to keep up with the currency of the data. But a forum like this and regular interaction in conferences and publishing and researching together really helps us work towards that end.
Thank you.
Okay, I'll move on to our final speaker for tonight. So it's Professor Bogda Kozwara. So Bogda is a senior staff specialist in medical oncology at the Flinders Medical Centre in Adelaide. She leads a survivor research programme at Flinders University Health and Medical Research Institute. Bogda is the past president of both COSA, so that's Clinical Oncology Society of Australia, and MOGA, the Medical Oncology Group of Australia. Chairs the psychosocial group of MASC, and leads the global partnership on self-management in cancer. Sorry, I was just swatting a mosquito or something there. And Bogda has been recognised as a member of the Order of Australia for services to oncology through clinical practice, education and research. So I'll hand over now for a presentation.
Thank you very much, Aisling. It's great to be here and talk with you about cardio-oncology and add the medical oncology perspective into the discussion. You have already heard a number of important points about the state of play today and the priorities for the future, and I'm going to try to build on them. And given the time of the day, I'm going to cut straight to the take-home messages. And my take-home messages are that cardio-oncology is not just about anthracyclines and Herceptin, and it's really a growing and evolving field. Unfortunately, the level of evidence to support practice is still quite low, and there are huge gaps that really need to be addressed by research. And we need to focus on appropriate and innovative models of care. And some of the questions that we've just heard had touched on that. So let me go through these 3 points in a little bit more detail. And I should probably start by recapping of how I started my cardio-oncology experience. When I trained in medical oncology, there wasn't even a Herceptin. We recognized that treatment with anthracycline triggered a request for a MAGA test. We didn't use echoes then, and we just chased the ejection fraction, which was numerical without any pictures or GLS data. And we knew that minority of patients would carry the risk of development of cardiac failure, and that was just unavoidable price to pay for the successful cancer treatment. But the the reassuring message was that this was a rare toxicity. And so I thought, when I was a junior oncologist and I saw a patient with non-Hodgkin's lymphoma who I treated, and of course his lymphoma was cured, but subsequently a few years later he developed a severe cardiac failure. And at that time, I thought that he was going to kill me. And for many, many years, as we were waiting for the heart transplant to eventuate, we would reflect on the trauma of the toxicity of his treatment, even though the cancer was cured. So that really sort of got me thinking and got me interested in the discipline. But of course, the discipline has progressed further, and now we know that it's not just anthracyclines. And in fact, if you were to look at the current cancer treatments, there are some forms of cardiovascular side effects attributed to most of them, and they do not just apply to the heart alone, but also to the blood vessels. And in fact, with the newer cancer treatments, there's perhaps toxicities that we are not even aware of. So I think that this is very much a growing field, which adds to the complexity of what it is that we're trying to manage. Also, as has already been mentioned, we are beneficiaries of the successful cancer treatments. So the focus of cardio-oncology is also a reflection of the fact that very large proportion of patients would be cured of cancer and hopefully enjoy the long life expectancy, where the relative contribution of mortality, of morbidity from cardiovascular disease become more important. And this is the data for breast cancer that shows that for women who are older postmenopausal women with breast cancer, after about 10 years of follow-up, mortality from cardiovascular disease exceeds that of breast cancer. So if we were to provide benefits to the patients, we really need to address mortality from anything, whether it is cancer or cardiovascular disease. And that really sort of is a very compelling reason for focusing on comorbid conditions like cardiovascular disease. And of course, that is not an issue that is unique to breast cancer. In fact, it cuts across a number of cancer types. This is the paper that was published only last year from Tasmania, with Tom Marwick as one of the authors, that analyzed mortality data in a data set from the Tasmanian Cancer Registry and showed that cardiovascular disease was a significant competing cause of mortality, here in red, for both for men and women across most cancer types. And what the researchers had done as well is that they looked at the question of whether the mortality rates for cardiovascular disease were similar or different to what's expected to general population. And what they found is the mortality rates for cardiovascular disease were higher than what you would expect for general population. Now, at COSA only a couple of weeks ago, our group had presented similar sort of results of a similar study from South Australian Cancer Registry, when we looked at 32,000 people with cancer and who survived for at least 5 years after cancer diagnosis, so long-term survivors, where you would expect that their life expectancy should be similar to the normal population. And we looked at the questions of what was their mortality rate in comparison to the general population, and what were the most common causes of death. And we found that cardiovascular disease was a significant common cause of death, similar to the other studies. But we also compared what was the mortality rate for cardiovascular disease deaths for the population. And similarly to what has already been presented, the standardized mortality ratios for overall risk of dying was higher for the cancer patients than the general population in South Australia. Similarly, standardized mortality rates for cardiovascular death was higher than the general population of cancer for general population in South Australia. But the important point was that standardized mortality rate was increased for all cancers except for skin cancer, and cardiovascular standardized mortality rate was increased for every single cancer. Now, many of these cancers are not treated with cardiotoxic treatments, and yet their mortality rate is increased, which begs the question of what is the reason. And Furthermore, in terms of our evolving field, we are beginning to understand, or at least pose some questions about what are the mechanisms of cardiovascular disease in cancer. And this is an example of a very elegant experiment where mice with growing cancer cells of breast cancer were experimented on in such a way that the myocardial infarction was created by tying off a coronary blood vessel. And the researchers measured what happened to the breast cancer in mice with myocardial infarction versus those without. And what they have found was that myocardial infarction accelerated growth of breast cancer through its stimulation of immune mechanisms. Now, there was an accompanying editorial in the Nature Oncology journal that argued that cardiovascular disease and cancer must have some form of molecular communication, whether the two are interrelated, which is really quite fascinating, because if we could understand the mechanisms, we could potentially identify the targets for intervention. And this connects with a paper that could have gone unnoticed a few years ago, which is this one, that showed in the human population of people with breast cancer, women who were treated with cholesterol lowering medication had better breast cancer outcomes. So perhaps if we're thinking about the interventions to manage cardiovascular disease, we may not just improve cardiovascular disease outcomes, we might actually improve cancer outcomes. So potentially we might get two for the price of one, and that's probably the most exciting aspect of this field going forward. So we really need to start thinking about what is the mechanism of how the two interact. And we've already heard about the direct treatment toxicity. We've also heard that both conditions share the risk factors, but there's also this molecular crosstalk that might explain how the two conditions interact. And there is probably another thing, and that is perhaps a little bit more mundane, and that's what's happening at the health service delivery level, where perhaps patients with cancer or their healthcare providers might neglect cardiovascular disease and focus on cancer first and foremost without managing the risk factors. So we need to have a better understanding of what it is that creates those results in cancer patients. And there might be other mechanisms, and we haven't really thought about them, and that requires further research. But there is, of course, a word of caution here, and that is patients do not just have cancer and cardiovascular disease. Many of them would have other comorbidities, so very often they cluster. They might have diabetes, they might have obesity, they might have poor lifestyle, like inactivity or poor diet, or they might live in an environment of socioeconomic disadvantage and have limited access to health services. And in terms of addressing their healthcare needs, we really need to tackle all of those, and that's a pretty complicated business. So moving on to the second part of my take-home messages, let's look at the evidence. And unfortunately, overall, the level of evidence is still low. There is a significant opportunity for further research, but what we have at the moment is not that impressive with occasional exceptions. Yes, there are many guidelines. We've already heard about the ASCO guidelines. There are European guidelines. There are ESMO guidelines from European Society of Medical Oncology and quite a few others. But they often focus on those common anthracyclines, Herceptin, cardiac failure, rather than all the other aspects of cardio-oncology. Let's look at those in a little bit more detail. This is a table taken from the ASCO guidelines, then very neatly divides points of intervention from identifying patients at risk to prevention, management, etc., etc. But if you drill down into the details, and let's use the recommendation 1 as an example, it's a pretty busy slide, but the first point to indicate is this one. Evidence quality, low, and that is the case for a lot of recommendations in cardio-oncology. Secondly, most of the focus is on the drug targets. So conventionally, oncologists have been taught to recognize the drug, the oncological insult and then try to manipulate that insult, either give anthracyclines or not give anthracyclines, as opposed to actually managing other things. It is true that the risk factors like smoking, hypertension, diabetes, etc. are mentioned, but if you were to go into the specific document, you would find that ASCO recommends that you should recognize them, but doesn't necessarily argue of how to manage them or who should manage them. And if you think that that is because the guidelines are a bit old, published in 2017, the more recent data is not that different. So this is the guideline taken from 2020, the American Journal that summarizes and tries to marry the American guidelines and European guidelines for cardiovascular toxicity. And this is a table taken from it, and I'm sort of staying with anthracyclines because at least I'm building on the theme. But you would notice that the algorithms are very busy. They argue for cardio-oncological evaluation, lots of tests. Troponins are recommended, including every week. I believe that the data on troponins is variable, and I'm not sure that we necessarily have a capacity nor evidence of benefit if we were to apply to that approach to every patient that receives anthracyclines, let alone identifying who it is that is going to be doing all this work, whether this will be a medical oncologist, cardiologist, GP, a nurse, or someone else altogether. So I think that we need to really apply these recommendations to the real life environment and ask of who should receive which interventions and by whom. Moving on the evidence, this is the paper from our group, again presented at COSA, where we actually try to drill down to what is in the literature with regards to the implementation of recommendations for cardio-oncology. And we screened 3,500 of papers looking for systematic reviews and meta-analyses, so high-level, high-quality overviews of interventions in cardio-oncology for any cancer that would give us some indication of implementation. And what did we find out? 14 papers, and you would see that there were 6 papers that really provided evidence for cardioprotectants. There were 6 papers that looked at some form of testing, diastolic parameters, echoes, troponins. There were 2 papers that summarized evidence of benefit of exercise, and 1 study that was inconclusive on coenzymes Q10. I acknowledge that these review papers do not capture studies like SUCOR, so there is evidence in primary papers, but at the review level, not exactly groundbreaking material to change practice tomorrow. And most importantly, they gave minimal detail on how or by whom these interventions should be implemented. So there's certainly a gap in evidence with regards to directing practice. So what we need to do is we need to really figure out how do we identify patients at the highest risk of adverse outcomes, and we need to do more than just recognize the target drug. We need to estimate impact of risk so we can provide that information to patients. And we need to estimate the magnitude of benefit. Just having high risk does not necessarily mean that you're going to have high benefit. That may or may not be the case. We need to build that information into the appropriate shared decision making. So we need to be able to translate that information into tools and calculators that are meaningful to patients. And we need to consider these estimates at the individual care level, but also at the population level. So we can consider how do we address this at the population care delivery. Which brings us to the topic of, do we have the right models of care to deliver this type of care? And I think cancer care is unique, and the unique requirements of cancer care need to be taken into account. Many cancer patients would have a surgeon, a medical oncologist, a radiation oncologist, potentially a rehabilitation specialist, a cancer care coordinator, not to mention the general practitioner. And if they have other comorbidities, they might see a respiratory physician, an endocrinologist, whoever else. lots and lots of people, adding another service is not necessarily the right solution. I think we need to figure out a way of how do we integrate that into the overall care delivery model in the most user-friendly and cost-effective way, and how do we align it with the priorities for the patients. And the priorities for the patients do not align with the medical subspecialties. This is an example of what I consider a really smart way of prioritizing survivorship care. And that's an example of the model of survivorship care for prostate cancer that was recently published from the Prostate Cancer Foundation of Australia by Jeff Dunn and colleagues. And what this model shows is that, first of all, a person affected by cancer is in the center and they have their own agency to decide what's important for them. And around them, we have interventions, health promotion and advocacy, shared decision making, care coordination, and vigilance or surveillance. And I think that this model would apply very well into the cardio-oncology model, but we would need to really grapple with the issue of who does what. So the challenge for us would be we need to deliver patients care and answer a question of what does oncologists do, what does cardiologists do, what's the role of the GP or nurse? Is it going to be delivered face-to-face or online? Because patients who often have most comorbidities might not have easy access to health services. What is the role of the patient in their own self-management, which has been shown to be effective in chronic disease management? And how do we integrate it with all the other things that are going on? We need to consider how we deliver care from the population perspective. And how do we need those most in need? Patients with higher rates of comorbidities in Australia, those with worse outcomes for cancer and for cardiovascular disease, are not the patients that attend private or even public cardio-oncology clinics. So we need to be quite honest about who needs the care the most and are we genuinely reaching them. And the other thing is we need to consider the difference between creating novel therapies and making sure that we provide the existing therapies. This is the diagram that I borrowed from Paul Glashu's paper. And Paul is the health services researcher and GP academic at Bond University in Gold Coast. And he talks about the underuse of care, where the gaps in healthcare outcomes are caused by lack of access to the stuff that we should be doing where the evidence is well established, either because there is no access to healthcare. For example, if you cannot reach a clinic or you live in a rural or remote area, or because there is no intervention accessible to you or available to you, or the intervention exists, but the clinician may not be offering that for whatever reason, or the patient does not wish to adhere because they do not know that the intervention is beneficial or it's not a priority for them. Let me give you examples of two of those. The first one is the drug that we've already mentioned, and that is cardioprotectants for anthracyclines. Now, in adult medical oncology, I have never used it. And I suspect the reason is not that the evidence is not compelling, but because oncologists tend to fear that we might deprive patients of favorable outcomes if we're treating them with curative intent. And of course, back to the message that I've started with, and that is cardiac failure is a very rare complication of cancer treatment. So this is an intervention that's supported by evidence, but pretty much never used, perhaps maybe with the exception of the pediatric population. I'll give you another example. This is the results of the study by Emily Banks on the general Australian population. Emily looked at what is the profile of risk for general cardiovascular disease in the general population and what is the uptake of appropriate preventative medications, those drugs that manage blood pressure and manage lipids. And there are 6 different categories of data here according to gender and age. And for each of those, there is a separate bar that presents uptake of medications according to the risk of cardiovascular disease in the future. And pretty much the 3 bars from that show risk of 10 to 15% onwards are the ones where people should be receiving blood pressure medications and lipid lowering medications. So really these boxes should be filled with dark red bars almost to completion. And the fact is, they're not, because for whatever reason, the uptake of this medication in the general Australian population is still very, very low. So if we wanted to do something really good tomorrow, we should be ensuring that we're adhering to this type of care where the evidence is well established. And if you think that that's bad for the general population, spare a thought for the cancer population. This is data from Aaron Sverdlov's group in Newcastle. They analyzed medication data for about 300 people that attended John Hunter Hospital cardiology service at Newcastle, and they compared cardiac medications for appropriate risk factors for people with cancer and without. And you would notice in this red box that people with cancer had even less preventative medications than people without. So there is stuff that we could do that's based on general preventative care tomorrow, but we're not doing it. And when it comes to this wonderful crosstalk between cancer and cardiovascular disease and the drugs that could do two for the price of one, that is an area under construction as of today. And I hope that there'll be research in that space, but we're not there yet. So how do we put it all together? Well, I've already told you the take-home messages about 3 times, so I'm not going to repeat them, but I'm going to try to give you my crystal ball take-home message of what it is that we should be doing. And first and foremost, I think that we should be building partnerships that focus on research, care advancement and policy, and meetings like these where we can really talk about all the different things that we do know and that we don't know are wonderful opportunities to start the conversation. Secondly, we really need to build the evidence. We need to identify risk, we need to identify mechanisms, and then when we know what the targets are, then we can build sophisticated interventions that can produce compelling outcomes. And we really need to understand what outcomes we desire and measure those outcomes both at individual and the population level. So I think there is plenty of work that needs to be done. And my low and perhaps not so low hanging fruit list here is we really should agree of what is the minimum standard of cardiovascular disease assessment, i.e. what it is that every person with cancer should be assessed for and by whom. And you would notice that I use the term cardiovascular disease assessment as opposed to cardiotoxicity because it's more than the heart and more than toxicity. Perhaps we need to update the language as well. Secondly, we need to develop some good patient resources on cardiovascular disease and cancer. There are none in Australia at the moment. There is information on cardiotoxicity of specific cancer drugs, and some of the best ones is actually from EVQ. But if you go to the Heart Foundation, there is no dedicated resources for patients with cancer and cardiac disease. So we need to really get our skates on. And if I can judge by the number of consumers at this call, there is definitely an interest in that space. We need to improve on our data capture. We need to have a register of new drugs and their toxicities. We need to collect cardiovascular disease outcomes in clinical trials that we do. And we should really think about a registry data on cancer registry data on comorbidities. And our cancer registries can do that. They just don't do that. So all these things are actually relatively simple, relatively inexpensive, but they haven't been done yet. The bit that is probably a little bit more expensive and more complicated, so maybe not so low hanging, but important, is we should really build the cardiovascular disease and cancer research collaborative group so we can actually start collaborating at the national level routinely and actually prioritize some of the research that we should be undertaking. So I'm going to finish by giving you examples of some wonderful innovations that really popped out literally over the past 3 weeks. The first one is, I've only just learned that there is an Australian cardio-oncology registry. This is their website, and it started with pediatric population, but it's now expanding to adult population, and they're very happy to welcome collaborators, and I'll be talking with them as soon as I can get to them. And the second one is the Australian Cardiovascular Alliance has just established its cardio-oncology research group or interest group. So now there is a beginning of conversation at the national level of what the priorities should be. So I think the future is bright, but there is a lot of work that needs to be done. So I'd like to end by acknowledging the research support that has supported my work in this area so far. And these are my contact details. I'm very happy to answer questions via email, and I'm very happy to answer questions now. Thank you very much.
Okay, thanks Bogda for that fantastic presentation and all of our presentations this evening. And I was very happy to see that, you know, indeed cardiotoxicity is not just about anthracyclines and trastuzumab. So an example of this would be with the immune checkpoint inhibitors. So they've been around for a few years, but it's only recently in the current international guidelines at NCCN that have actually added guidelines specifically for cardiotoxicity. So we all are still learning at this stage. We've also got the TKIs for the QT prolongation, and I don't know if you've got a comment around, so obviously a lot of these patients now are in the community on these agents. They may be on drugs that interact, so like antidepressants and other things. So it's about getting the message out to GPs or people that are surviving with cancer. Have you got a comment?
Yes, look, I should probably start with an anecdote, and that is I once ran into a colleague of mine who's a hematologist working in the same clinic, and he said to me, "What do I do with all my patients on CML? They have excellent outcomes for their CML, but they receive drugs that really mess up their cardiovascular health, in particular lipids. And my problem is the GPs say, we don't know how to manage these, so we don't want to do it. The cardiologists say, we do not want to manage lipids. You know, we just like to do angiograms. No offense, Tom. And the hematologist stands there and says, look, you know, the last time I checked someone's lipids was 20 years ago when I was in medical school. So who's going to manage this? So I think it's a real problem, and we need to find better solutions. And perhaps, I guess my view is that we need to invest in clinical pathways. So we actually describe not just what needs to be done, but who should do it. And I think we need to risk stratify patients according to complexity. There are some who genuinely have very complex needs, patients with complex cardiovascular disease, recipients of bone marrow transplants, who really need sophisticated, complex, multidisciplinary specialist team. And there are others where the care plan is very well handled and managed by the GP, and the GP is comfortable in doing so. So I think we need to we need to figure out how to tailor interventions according to patients' needs. And that aligns very much with the general principles of survivorship care.
Okay, I have a question from the chat. So would exercise be a valid intervention that gives positive outcomes for many comorbidities, including cardiovascular disease? And if so, how do we improve a multidisciplinary approach with allied health? So I'm sure that's anyone on the panel.
Look, I think we're preaching to the choir here. There is plenty of data that exercise is beneficial. And I think that there are good models of care delivery in terms of exercise. So I think we just need to figure out a way. In fact, perhaps one of the barriers is that we need to get clinicians to build prescriptions of non-pharmaceutical agents into their portfolio of prescribing. You know, we're very good at kind of writing, you know, antiemetic scripts, but we perhaps need to practice the skill of writing prescriptions for exercise. And that involves checking the adherence to the intervention when you see the patients in clinic next.
Okay, Tom's got a...
So Bob, I have to get back at you for your comment about cardiologists just being interested in angiograms by saying that I'm really sorry, but that's a terribly naive approach to exercise. So we as cardiologists really spend a lot of time talking to our patients about exercise, and there's a lot of words said, but very little exercise done. And so I think that the process of exhorting people to exercise actually, hasn't worked very well. And we need more than just the exercise prescription. We probably need to have, for the high-risk patients that you very appropriately talk about, we probably need to have a process of referral to exercise physiologists, e-health strategies such as apps that will guide people about what to do. Cardiac rehabilitation is a case in point. We know after a heart attack that people's survival is enormously benefited by going to cardiac rehab, but fewer than 50% of patients go. So this is a need for system redesign, really. And I think it's more than just instruction. I think we need some research about how better to deliver this.
I've just got a comment with regard to your the not so low hanging fruit, Bogda. So when I was looking earlier on preparation for this evening, so I noticed the British Cardio Oncology Society, they have collaborated with Macmillan, and they've got a specific booklet on heart health and cancer, and it's practical advice for patients during and after cancer treatment. So I'll put that link in the chat, or we can make that available. And they've also developed one for health professionals and primary healthcare as well. So that's endorsed by them and the Oncology Nursing Society. So I'll make those links available for the audience tonight. Okay, has anyone got any other questions? I'm just conscious of the time and we've eaten into your evening. So we've come to the end of the night. So, sorry, someone got a question? No, just anxious to get to the dinner and hit unmute. So I'd like to thank our three speakers for tonight for their knowledge and insights into cardio oncology. Thanks to every one of you for taking part in our first Cancer Conversations meeting. So as we said at the beginning, we'll be running more of these sessions, so keep an eye out for some of the emails. And Tia will be sending a evaluation, so it'd be great if you could complete that so we can improve on these meetings. And I'm not sure if, Tia, have you got one final poll questions, or are you happy to wrap it up? One last one. There we go.
I'm wondering if we could get send all the talks tonight.
Yes, I think they will be made available and they will be online, so the link will be distributed to everyone.
Thank you very much. I'd like to do that because
No problem.
I'd also like to be able to talk to the specialist one-on-one after I've read their report.
Okay.
That's if they will let me talk to them that way.
Well, I can't answer for them, but let them be the judge of that. But thanks very much. So we will wrap up if that's okay, and get back to your evening. But once again, thank you very much for the inaugural Cancer Conversations meeting, and wish you all a good evening. Thank you.